presentation in the program. And our next speaker is Professor Dr. Alaa Management, Professor of Clinical Oncology, Alexandria University. He will give us a talk about the management of systemic treatment. Hello. He will give us a talk about the management of early HER2 positive breast cancer patient, the neoadjuvant and the adjuvant setting. I think this is very important topic, and this is one of the practice that had changed the course of HER2 positive breast cancer, especially in young women. Please, Dr. Alaa.
Thank you very much, Professor Abdulsalam, for this kind of introduction, and I'd like to thank Roche Pharmaceuticals for giving me the opportunity. As Professor Abdulsalam mentioned, this is a really important topic because the pendulum is now changing in favor of preoperative or neoadjuvant therapy. What do we have now? We have an improvement in the outcome of breast cancer patients. As you can see, that half of that is due to screening and half of that is due to systemic therapy, not local therapy. Local therapy did not improve the outcome. I mean surgery and or radiotherapy. We have to remember that, okay? What are the key characteristics of HER2 positive breast cancer? 20% of the women, 1 in 5, will have HER2 positive disease, 20%. Usually patients are younger with more aggressive disease and propensity to spread. You can see actually breast cancer remains a significant health burden even after improvements in adjuvant therapy. In all countries, even in the States, a very wealthy country, it's a real health problem and needs so much attention, especially in the form of financing and the budgeting. So we definitely have more than one point to give us a decision for breast cancer patients. How do and what to do in the neoadjuvant preoperative setting, what kind of adjuvant treatment, and do we need extended adjuvant therapy or no, especially for HER2 positive patients. So why neoadjuvant systemic therapy? I believe that at least triple negative patients, and I will come to that in my presentation, and HER2 positive disease should receive neoadjuvant therapy, okay? And mind you, I know that that will not be liked by our dear colleague surgeons, but we are doing surgery only by habit because we were raised and taught that surgery comes first, which has no scientific basis, especially in the HER2 and the triple negative basis. So we're trying to conserve and do lumpectomy. We try to tackle the metastatic disease early on in the disease course. And most importantly, we'd like to have a so-called response-guided approach and assess the pathologic response. Why is that? Because the adjuvant treatment is a kind of blind treatment. You give the patient chemotherapy when there's no disease to measure, and then you assume that this patient is benefiting from the chemotherapy while it's not. And you see that in your face when you're doing neoadjuvant therapy, if the patient is responding or not responding, okay? That's the difference between both. So who should be considered? Mainly, as I mentioned, HER2 positive, any tumor that's 2 or above, and even lower than that. I will show that in a slide. Node positive patients with high tumor volume to breast ratio, lymph node positive disease, high risk features, as you already know. I will not go through the exact details of the neoadjuvant trials, but I mean just going into a glimpse. This is the new sphere, okay? The new sphere was actually a phase 2 trial, but it got the approval of neoadjuvant Perjeta for those patients. As you can see, patients did receive anti-HER2 therapy with taxane, and then go surgery, and then we'll go for the usual FAC treatment. And actually, these are the characteristics of those patients, but most importantly is the very lower part of the slide. You see above 55% complete pathological response rate. More than half of the patients come out with this type of treatment with no evidence of disease. Mind you, that they did not receive all the treatment before therapy, because I mean, usually nowadays, if you are going for neoadjuvant chemotherapy and your patient is responding, continue. There's no difference, and there's no point to give 3 cycles and then go for surgery and then another 3 cycles. There's no point whatsoever. And I'm quoting the words of Ortho Baggi. The patients who are candidates for adjuvant systemic chemotherapy are the patients who are candidates for the same treatment but given in a neoadjuvant form, because at least there's no difference between both in terms of disease-free survival and overall survival. So at least give this treatment in front of your eyes rather than give it blindly, as I said, in the adjuvant setting. And we have already seen that in the hormone negative cohort, you have a patient with PCR and a patient with no PCR. The difference is quite significant in the patients with hormone negative. I'm not saying that it's only for hormone negative patient as per the hazard ratio. Yes, here the hazard ratio is 0.34, meaning the 66% of the patients do benefit, but still, if you look at the hazard ratio in the hormone positive patients, is 0.5, exactly 50% of the patients. So I mean, don't believe that in the HER2 positive patients with ER positive disease, they don't benefit from the neoadjuvant chemotherapy. It's not, or the systemic therapy. They do benefit still. And this is the timeline of the different anti-HER2 therapies. Some trials can give us something like even 70% complete pathological response rate, which is an important surrogate. Those are the patients who really do well thereafter when they finish their treatment. This is the pooled analysis of the German neoadjuvant chemotherapy, and who any of you who's following the German, they are the best in the neoadjuvant breast. They have very classic and systematic way. They go step by step in different trials, and their data is very strong and credible data tell us that systemic neoadjuvant therapy in HER2 patient is the line of treatment, as you can see from data in terms of disease-free survival and overall survival. And this is actually, if you'd like St. Gallen, the expert opinion, there is a strong consensus on the paradigm shift from adjuvant to neoadjuvant, as the experts answered yes by 98% to go for neoadjuvant rather than adjuvant therapy. Okay, so given all of that, the FD approved the PCR as an important surrogate in the management of patients with neoadjuvant systemic therapy, and thereafter comes all the big bodies. The NCCN would say the same, the St. Gallen, as I mentioned, ESMO, the National Institute for Health and Care Excellence in England, which is a very respectable body to give us guidelines. So all has approved that, and all is talking about PCR as a very important surrogate to follow our patients with. Okay? Nowadays, this is actually the strongest statement I've ever seen. That's by ESMO, by the way. Okay? It's saying that if you are treating a patient high risk with HER2 triple negative breast cancer with no neoadjuvant therapy, it's not ethical. This is very harsh. Okay? They dare to say that loudly. This an ethical obligation to give patients with HER2 and triple negative high risk patients neoadjuvant therapy. Okay? So there's no doubt about that. Now we come to an important issue, especially for HER2 positive patients. I mean, some of us think that the very small tumors do not need anti-HER2 therapy or do not need anti-HER2 preoperatively in the neoadjuvant fashion. Okay? Is that right? Actually, it's not. Why is that? Because after all we've learned through the last 20 to 30 years, that it's the biology and it's not the size of the tumor that makes a difference. We learned that. We've seen that in the clinic early on. We've seen patients with 5 centimeter tumor with not a single axillary lymph node and they don't metastasize. And we've seen a patient with 1 centimeter tumor that metastasized early on. And this is because the molecular profile and the high risk features for this tumor. So it's not the size, it's the biology. And you can prove that. Look at that. This is more than 1,000 patients telling us in very small low risk patients that HER2 on its own is a prognostic factor. You see that HER2 negative patients do better than HER2 positive patients, and those patients did not receive systemic therapy. This is the natural history of HER2 positive disease. Okay? Again and again, patients with even up to 1 centimeter or 2 centimeter, they differ only by their HER2 status without systemic therapy. So HER2 on its own is a bad, ominous, but bad prognostic feature that is present in those patients. So no patient with HER2 positive breast cancer is considered a low risk as long as it's already there in the invasive component. Sometimes we face that in very small tumors. And you've seen that the disease burden of the neoadjuvant chemotherapy, this is very important. When you do neoadjuvant chemotherapy, you have to care about different issues. One, what type of therapy you're giving, how to manage your patient duringly. You have to follow up your patient every cycle. Neoadjuvant therapy is a tedious procedure, okay? It takes from you a lot. You have to see your patient every cycle. You have to mark the tumor with a metallic clip, so you can guide the surgeon if there is complete pathological response. And afterwards, you have to look at the amount of residual disease, because not all patients go for complete pathological response. Some patients go or are left after surgery with different levels of residual disease, okay? And the residual disease makes a difference. Those patients with maximum residual disease, less, or no residual disease in triple negative, HER2, and to the same parameters, but with less magnitude in the hormone receptor HER2 negative disease. And that's why doing neoadjuvant systemic therapy is a joint work between the surgeons, oncologists, pathologists, and radiologists. Everyone should be there. And even the patient should be there to be encountered with the facts of the HER disease. And this is actually a slide by the pathology. Pathologists who do not know how to measure exactly and tell you about what's left and how significant is that should not go for assessment of neoadjuvant. I mean, أنا آسف إن أنا هتكلم في ده. You see patients, for instance, that you have already seen in the clinic that has something like 8 centimeter tumor, and then they go for something like 1.5 centimeter residual, and they had a mastectomy, for instance, and they go to the pathology and they found that 1.5 centimeter, 50% DCIS, 50% invisible, and they just dare to write it insufficient response or no good response to systemic chemotherapy, which is very funny because they did not see the patient to start with. They did not see that the patient had 10 by 10 centimeter tumor, 4 quadrant tumor, because we don't work together, unfortunately. Okay, so again, we're left with residual disease, and this is the Catherine trial. The Catherine trial is a very simple but brilliant trial. What it did look at, it looked at the patients with HER2 positive tumors that are receiving systemic therapy and then anti-HER2 therapy, whether trastuzumab alone, pertuzumab, it doesn't matter, and then they are doing surgery, and thereafter are left with residual disease. This is for the non-complete pathological responders. And now they are randomized. Part of those patients will go for TDM1, and you know what's TDM1, Herceptin plus chemotherapy, or Herceptin alone, or trastuzumab alone, okay? To answer what is the optimal treatment for the anti-HER2 patients who come up after surgery with less than complete pathological response. And the data was in favor of the TDM1, and it speaks on its own. I will not go through the details of that curve. And that was in all subgroup analysis. It was there for TDM1. So at least we know that we should do something better than just giving trastuzumab in the adjuvant setting for those patients, okay? These are the secondary endpoints in terms of distant recurrence. You can see the difference, but not really in terms of overall survival. Another one way is to go for the extended adjuvant therapy afterwards, like using neratinib, okay? And this is the ExtraNet 5-year update using neratinib versus placebo. And again, though the difference is marginal, but it's significant, by the way, for extended adjuvant. So it tells us again another lesson that there are patients who need more treatment rather than to stop the treatment early, okay? This is the 5-year invasive disease-free survival in the hormone receptor positive data for extended anti-HER2 therapy. Now we come to the affinity, which is nowadays the landmark trial for the adjuvant patients with HER2. What's the affinity? The affinity simply is patients with positive HER2 breast cancer, nearly 5,000 patients, a very good number of the patients who underwent surgery. Now they are being randomized to receive chemotherapy plus Perjeta Herceptin or placebo Herceptin. So Herceptin versus Perjeta Herceptin, okay? That trial at the beginning, at the very early analysis, was harshly attacked because everybody thought that this is a very expensive drug. You do not need to add that to trastuzumab, and the margin of benefit is so small. And that actually was somewhat true early on. And if you see that, why is that? Because at the 3-year analysis, there was a significant difference, but it was small. So nobody really was enthusiastic about that. But at the second interim analysis at 6 years, which is our recent update, it shows a good 0.76, 24% of the patients do benefit by the addition of pertuzumab. But I'm not saying that every single one should have it in our country, for instance, because we have to look into our finances, especially in the adjuvant. Nowadays, our insurance, for instance, approves the combination of pertuzumab and trastuzumab in the neoadjuvant setting, okay? but not yet in the adjuvant setting. And we have to discuss that with our officials, our budgeting people, to tell us exactly where to have that. But the combination works, yes, it works. And these are all the subgroup analysis. Namely, the benefit is there in high-risk patients, namely node-positive subgroup, and very marginal in node-negative subgroup. So at least you have a clue. Use it at least in the high-risk patients, okay? Namely node-positive disease. These are the analysis. I will not go through the details. I already mentioned that. And this is the affinity efficacy summary. Pertuzumab or Perjeta did add to the benefit of trastuzumab with chemotherapy in the adjuvant setting, especially in high-risk patients. Okay. Whether to de-escalate or de-escalate or escalate treatment with HER2 positive disease, this is important. And why is the issue of de-escalation always coming up in HER2 positive disease? Because it's the HER2. You know, we are escalating the HER2 or the anti-HER2 therapy, but maybe we could de-escalate the chemotherapy backbone. Why is that? Because it's in the HER2 tumors, the HER2 is the real driving mutation behind those tumors. Yes, chemotherapy helps. Nobody can dare not. And the response of chemotherapy in HER2 positive disease is high. But again, it's the HER2. And you know from all the guidelines in the metastatic, which is not our part today, you continue with the anti-HER2 blockade even if the patient develops resistant to anti-HER2 therapy, okay? So this is a de-escalation trial. The Fergain trial assessed early metabolic response by PET. This is one thing, not only by clinical findings, and these are the eligibility criteria. This is a very complicated design. However, concentrate on only arm B, okay? Those are patients receiving taxane, Perjeta, Herceptin, and then evaluated by PET before and after. And this is actually the PET responders. Something like 79% of the patients do respond as per the PET parameters. And you can see the difference in complete pathological response. Most importantly, the rate of breast conserving surgery can follow that up, which is very important to our women. It does not affect the survival, we know that, but it's important for any women's image. And the conclusion of that trial, that nearly 40% of the patients who started dual anti-HER2 blockade with Herceptin Perjeta were PET responders, achieved a total complete pathological response. So at least you have a hint, because almost always when you are dealing with neoadjuvant systemic therapy, yourself and your patient will be asking you, so what about my situation after I finish the neoadjuvant therapy? Could I achieve complete pathological response? You cannot tell her. But at least we're starting to have some clues. This is a PET study that's telling us that the patients who respond early after 2 to 3 cycles to neoadjuvant therapy will hopefully achieve complete pathological response. So at least you have something. It's building up. Last but not least, MRI can also, or PET CT, or a combination of both, and that was already analyzed in the NeoAlto trial as an imaging biomarker, is telling that. Last but not least, this is the TRAIN trial trying to avoid using anthracycline. We know that patients are subjected to 2 cardiotoxic elements or agents, Herceptin and anthracycline, and these are both not good for the heart. And you see here, upper arm does not have any anthracycline, and the lower arm has 3 cycles of anthracycline followed by the usual taxane anti-HER2 therapy, and there's no difference whatsoever in this trial. You can safely go without anthracycline. I'm not saying that this is in all guidelines, but this is something to think about. In terms of event-free survival, there's no difference between using and not using anthracycline, and this is one of the bell jewels of treating patients in the neoadjuvant. You can have an answer for a certain agent and a certain question you have in the neoadjuvant with 400, 500, 6 patients. But if you want to do that in an adjuvant trial, you need at least 5,000 patients and more time and more money. So neoadjuvant is very good for that. This is the disease-free survival by complete pathological response. Patients who achieve complete pathological response do better than patients who do not. These are the conclusions telling us that there is no difference. Now, this is actually that's something that almost always the surgeons come up with this data. What are these data telling us? This is very respectable data of the trialist group, early breast cancer treatment trialist group, is showing us the following. I have to put my glasses, sorry. Okay. In the neoadjuvant and adjuvant, in breast cancer mortality, there's no difference whatsoever. Neoadjuvant, adjuvant, distant recurrence, there's no difference whatsoever. Adjuvant, neoadjuvant, all-cause mortality, no difference whatsoever. But there is a difference in terms of local recurrence in favor of the adjuvant therapy as neoadjuvant. So they almost, some surgeons do put that slide in their meetings. But it's not true. Why is that? Okay? I'll give you the limitations. Okay. Because this is the NCCN that's answering to that. Some studies suggest an increased risk of local regional recurrence following use of preoperative chemotherapy. I have to read it. And the trials analyzed, because this is something like 15 to 20 years time. Okay, this is old patients, old data patients managed. The trial analyzed used chemotherapy regimens that are no longer standard, did not include targeted therapies, and did not use modern imaging techniques. This is very important. Okay, I guess that answers the question on its own. Now we have some technical points. The presence of microcalcification, does it really disappear with neoadjuvant chemotherapy or not? This is something that people are still working on. We are not saying neoadjuvant chemotherapy to eliminate surgery whatsoever, because up till now, the only way to document your response is that taking the tumor out, which is surgery, and then do pathology. You cannot assess the patient completely or efficiently without doing surgery. So forget about that. It's not the time for that. There are some non-randomized trials. The British and the Italians have started that, but it's not in the guidelines. Okay, this is for my junior colleagues. The usual contraindications to breast conservative surgery is the same as before or after neoadjuvant chemotherapy. There's no point of avoiding surgery. Maybe 20 to 30 years we'll see that. And the accuracy of MRI is there. There are false negative rate of needle biopsy. This is why you cannot rely of needle biopsy, and you have to do surgery post neoadjuvant therapy. And also assess the PCR is very important to give the adjuvant trial. I already mentioned one, which is the Catherine trial. And the other one is the CREAT-X trial, where you give 6 months of Xeloda or capecitabine if you don't have complete pathological response in triple negative patients. And still remind you that surgery is a low-cost, effective modality. We're not saying that. We're only talking about the sequencing of treatment. We're not saying about eliminating surgery from the treatment algorithm. Thank you so much.